So I'd like to introduce our grand round speaker. So I'm sure most of you know Aqsa Nasir. She's currently a fourth-year resident in our program. And she came to our residency after medical school training at the Rawalpindi Medical College in Pakistan. And she also did a histopathology residency at the Aga Khan University Hospital in Pakistan. She spent time working in Pakistan and Saudi Arabia before she moved to the US and did a one-year research fellowship at our neighbors to the south at Mayo Clinic in Rochester. We were fortunate to recruit Aqsa to our residency program. She's been a pleasure to work with and has been academically quite productive with 8 poster presentations, 6 published papers, and an additional 2 papers submitted for publication just during her time with us here. So I think these numbers demonstrate her desire to pursue research, and she also demonstrated that to me when she actually approached me about doing this project on follicular lymphoma, through all the administrative steps we went through on this project to where we are today. And I'll turn it over to let her tell you about that. Thank you.
Good morning, everyone. I'm Aqsa Nasir, fourth-year pathology resident, and today the topic of my talk is follicular lymphoma, clinical significance of Ki-67 proliferative index, PD-L1 and LAG3.
Aqsa, move the mic closer to your mouth, please.
Is it good?
It's better.
All right, thank you. I hope you all have got your morning cup of coffee and enjoyed the delicious donuts as we cruise through this presentation. So first I would like to talk about the sources of funding for this project. I was very fortunate to get the resident research grant of $2,500, and this was used for pulling the blocks, cutting unstained slides, and performing the Ki-67 staining. And I'm thankful to Dr. Perch and the member of the Resident Research Grant Committee for approving my proposal. The second part of this funding was kindly provided by Dr. Bakanova, and that was used for PD-L1 and LAG3 staining. So the objective of my talk today are to describe the characteristics of follicular lymphoma, to discuss the clinical significance of low-grade follicular lymphoma with high proliferative index, and to analyze the utility of PD-L1 and LAG3 as prognostic markers. So this is the outline of our presentation. I'll briefly go over characteristics of follicular lymphoma, describe the clinical presentation, pathologic features. I'll discuss briefly about the therapy and prognosis, and give you background about our project, results, and finally, what are the future directions of our project. So follicular lymphoma is defined as a neoplasm composed of follicle central B cells, typically both centrocytes and centroblasts, which usually has at least a partially follicular pattern. It accounts for approximately 20% of all lymphomas, and it is the most common indolent non-Hodgkin lymphoma in the Western Hemisphere, with the highest incidence in the United States and Western Europe. It affects mainly the adult population, and there are very rare cases of follicular lymphoma which usually happen in age group less than 18 years. And the median age is 6th decade of life. Male to female ratio is 1:1.7. Majority of the follicular lymphoma happen in the lymph nodes, and the most common extranodal site is gastrointestinal tract. At the time of clinical presentation, most patients have advanced disease, including the peripheral and central enlarged lymph nodes and enlarged spleen. 40 to 70% of the cases show bone marrow involvement at the time of presentation. Stage is very important, and to assess what is the extent of the involvement, we take help of the imaging like CT scan, MRI, and PET scan. This is the macroscopic appearance of the follicular lymphoma. This is the cut section of the lymph node, and you can see the vague nodular architecture, and probably you can appreciate some bulging. This is because of the follicles. Spleen usually shows expansion of the white bulb with less involvement of the red bulb. Microscopic feature, it's a very important part in the diagnosis of the follicular lymphoma, and this low power magnification appearance of these nodules, large follicles, back to back with a monomorphic look and loss of polarity are important features. On high power magnification, you can appreciate the centroblast and the centrocytes. And the centroblasts are very important in follicular lymphoma because we use the number of the centroblasts in each high power field to categorize either low grade or grade 3 follicular lymphomas. So for grade 1 and 2, the total number range from 0 to 15, and for grade 3, if they are more than 15. Low grade further divided in grade 1 based on 0 to 5 centroblasts per high power field, and grade 2 based on number of 6 to 15 centroblasts per high power field. For grade 3, 3A, we have more than 15 centroblasts, however they are intermixed with centrocytes. And in grade 3B on the opposite side, it's the diffuse sheets of centroblasts, and they show some weak nodular architecture. Though 3A and 3B are lumped together, but they are very different in terms of their therapy and prognosis. So grade 3A are treated just like low-grade follicular lymphoma, and grade 3B are treated along the lines of more aggressive lymphoma, like diffuse large B-cell lymphoma. These are very nice images showing you histology of grade 1, grade 2, and grade 3A lymphomas. And you can see here, it's kind of hard to identify the centroblast. Here you can see relatively easily identifiable some of the scattered centroblasts, but the number will be 15 or less. And here in 3A, you can easily identify centroblasts, but they are intermixed with centrocytes. Immunophenotypically, grade B follicular lymphomas stain for CD20 and CD19, and they are positive for surface light immunoglobulin chain. They are positive for IgM, with or without IgD. And occasionally they can show a positivity with IgD or IgG or IgA. Most of the nodal low-grade follicular lymphomas show positivity with CD10, BCL6, and BCL2. 14-18 translocation is seen in approximately 85% of the follicular lymphomas. And this causes translocation of BCL2 into VDJ region of the immunoglobulin heavy chain gene. And this can be demonstrated in the lab by routine cytogenetic analysis, by PCR technique, which with primers that recognize BCL2 and IgH, and fluorescent in situ hybridization. Fluorescence in situ hybridization is more practical because we can use the paraffin blocks for this purpose. Several additional trisomies, monosomies, gains, losses, and other additional translocations are also additive. So coming to the prognosis and therapy. Follicular Lymphoma International Prognostic Index, also known as FLIPI, is very important to risk stratify patients based on prognosis. And this can help guide the clinicians when and how to treat their patients. And this requires clinical information, lab data, and imaging. Here you can see these are the parameters that are used for FLIPI score. And for the presence of each of these parameters, they get one score. And these all are added. And based on the total score, we risk stratify them. So for 0 to 1, it is low risk, and 10-year overall survival is 70%, as opposed to the FLIPI score of 3 or more, which is high risk, and you can see a significant decrease in the 10-year overall survival. So FLIPI score 1, which uses all those parameters that I described in the previous slide, was used more often in the pre-rituximab era. Now with the initiation of the rituximab therapy, we use FLIPI 2, which has some of the same features as we use in FLIPI 1. And the additional things are the nodal long diameter of large lymph node, more than 6 centimeter, and elevated beta-2 microglobulin instead of the elevated LDH is considered in this scoring system. Another important criteria to assess the tumor burden is GALF, and this uses the parameters of lymph nodes, what is the bulk, number of lymph nodes, whether spleen is involved or not, what are the potential complications, serum markers similar to FLIPI-1 and FLIPI-2, and the presence or absence of B symptoms. B symptoms include unexplained fever of more than 38 degrees Celsius, drenching night sweats, or loss of more than 10% body weight within 6 months. Regarding the algorithm of how the grade 1, grade 2, and grade 3A follicular lymphomas are treated, so this very nicely showed the flow chart depending upon whether there are symptoms or not, and also whether it is a low tumor burden disease or high density disease. And then these various options are discussed with patient. Another thing to keep in mind is, of course, patient's age and the comorbidities. I just wanted to emphasize on this point that this group is different from grade 1, 2, and 3A, which are lumped together for treatment, and 3B is treated along the lines of diffuse large B-cell lymphoma. Now coming back to our project. Back in 2016, when I was doing my lymph node rotation in HemePath, I noticed that we do follicular lymphoma, especially the low-grade follicular lymphomas, we stain them with Ki-67, and if the cutoff is 30% or more, we write a comment in the report stating that these patients need follow-up as they might do worse as compared to the low grade with low proliferative index. I ended up having a discussion with Dr. Yohi about this while signing out one of our follicular lymphoma case with the same features. And we gave reference to this article. This was published in American Journal of Pathology in 2005, and they discuss the very same point. So they have total of 142 cases of follicular lymphoma, 48 grade 1, 71 grade 2, and 23 grade 3. And they did manual estimation of Ki-67 under microscope, and these all patients were from pre-rituximab era. Here you can see it's a very nice demonstration of the proliferative index. Each dot represents a case in their study. And you can see there is gradual increase in proliferative index when you go from grade 1 to grade 2 to grade 3. This is the median for each group. They also included follicular lymphoma transformed, just for a comparison. However, they excluded the transformed follicular lymphoma from their final analysis. And you can very well notice here, there are some cases which have histology of low-grade follicular lymphoma, but their proliferative index is more similar to grade 3 or even the transformed diffuse large B-cell lymphoma. That was an interesting finding. So in their conclusion, including all grades, patients with less than 30% proliferative index had significant longer disease-specific survival than patients with more than 30% proliferative index. They did notice that there was some impact on the overall survival also, which was slightly longer in proliferative index less than 30%. However, it was borderline significant. So they concluded that this group of patients who had diagnosis of low-grade follicular lymphoma with low proliferative index is a separate group which clinically behaves more like grade 3 follicular lymphoma. So they proposed that these cases should be classified separately. There was another study that came out in 2007 from a group in Netherlands, and they also looked at the same feature. Their cohort included 51 patients with follicular lymphoma who were receiving uniform first-line treatment. And they used lymph node biopsies in all of their cases. And again, they did the similar way of estimating Ki-67. It was done under microscope by either estimation or direct counting. And the median proliferative index was 16.9 in their study. And they found out that low proliferative index predicted longer time to progression and longer overall survival. This very nicely shows the distribution of their cases for grade 1 and 2 and grade 3, and this is the median proliferative index for low grade and grade 3. And in comparison here, they included all grades, and their median proliferative index overall was 16.9. So the group of patients who had proliferative index less than medium did far better than the group of patients with median more than 16.9. So this another study, they also looked at the same features and analyzed their patients for Ki-67 proliferative index in follicular lymphoma. However, this time, digital analysis of Ki-67 was done instead of doing direct observation or estimation under microscope. So they have a total of 129 patients with grade 1 and 2 follicular lymphoma. It was a retrospective analysis, and they used a cutoff of 30%. So intrafollicular PI, which is proliferative index, less than 30% was associated with longer time to first therapy compared to patients with a proliferative index of more than 30%. So this study again found out that there was a statistically significant association of low-grade follicular lymphoma with low proliferative index with their time to first therapy. However, in contrast to these all published studies, this study, which was published by German low-grade lymphoma study group, so they analyzed 158 cases, and they did not find any correlation with overall survival or time to treatment failure. Another additional thing that they did was that they counted Ki-67 in follicular as well as interfollicular areas. So these findings made us think that, time to treatment, time to progression, and overall survival are widely variable. And prognostic factors are needed to stratify these patients who can benefit from upfront therapy. And the association of the Ki-67 proliferative index in the follicular lymphoma with recurrence, progression, and decreased survival is still unclear despite several published studies. And another additional thing is that the Ki-67 proliferative index in the intrafollicular area is not widely explored. So we thought about to start a project, and this is our team. So Dr. Yohi and Dr. Bokanova are principal investigators on this project. Livia was Hemong Fellow in 2016 when we started this project, and now she's on staff in Seattle at Swedish Medical Center. Ryan has been a huge help with all the stats, and Colleen helped us with staining Ki-67 and validation of PD-L1 and LAG3 stains. When we started the study, Dina was our study coordinator, and then later Dave joined us. Dr. Linden very kindly joined our project later to help us with staining and the scoring of the PD-L1 and LAG3 stains. Hira joined our project a few months ago. She's working on the digital analysis of all the scanned slides, and we are very grateful to Brian, who helped scanning all those slides in the barrier for the digital analysis. During one of our meetings, Dr. Bakanova recommended, how about we look at the PD-L1 and LAG3 staining, though initially we were thinking about doing only Ki-67, so we added these two stains also in our project. As you all know, that PD-L1 is programmed death ligand 1, and it is expressed on antigen-presenting cells and inhibits activation of T cells through its receptor PD-1. PD-L1 is apparently expressed on some epithelial malignancies and Hodgkin's lymphoma and may prevent effective host anti-tumor immunity. However, the role of PD-L1 in non-Hodgkin lymphoma is not very well characterized. So that is why we decided to pursue it. This is one publication. Livia found this article and shared with me. It was published in January 2018. And they looked looked at all the published studies of follicular lymphoma, and they have all of these studies have different characteristics, like simple diagnosis of follicular lymphoma undergoing treatment with R-CHOP, and follicular lymphoma group comparison of like transformed versus which did not transform. Some of the studies show that the low proportion of PD-1 is associated with poor overall survival and diffuse large B-cell transformation. Another study also said, yes, a good outcome is associated with higher follicular PD-1. But then there is another study which says that high percentage of the PD-1 cells in follicular lymphoma biopsy is associated with poor progression-free survival. So they concluded that this complex PD-1 expression pattern, the prognostic impact of the PD-1 expression in follicular lymphoma is inconsistent in the literature. LAG3 was another marker that we pursued, and it is a lymphocyte-activation gene 3. It was discovered in 1990 and was designated CD223 in 2000. It is also a self-surface molecule with diverse biologic effect on T cell function and acts as an immune checkpoint receptor. It is expressed on activated T cells, natural killer cells, B cells, and plasmacytoid dendritic cells. LAG3 main ligand is MHC class 2, and its function, the protein functions in the similar fashion like PD-1. This article, which was published in 2017 in OncoTarget, discussed the expression of LAG3 in follicular lymphoma. And they found out that intratumoral PD-1 positive, LAG3 positive T cells exhibit reduced function in vitro. In contrast, PD-1 positive and LAG3 negative T cells are immunologically functional cells. So they said that if you block both PD-1 and LAG3, it enhances the function of intratumoral CD8 T cells. And clinically, the LAG3 expression on the intratumoral T cells correlated with poor outcome in their study. And they suggested that these findings may be helpful for selection of immunotherapy for follicular lymphoma in future. So we did retrospective analysis of all newly diagnosed cases of follicular lymphoma, which were evaluated at University of Minnesota from January 2003 to April 2016. So in the beginning, we had total 137 cases to start with. After doing the detailed epic review of these cases, we excluded cases in patients with the patients no follow-up was available, or the in-house cases in which no tissue was available, so we couldn't perform any stains on these cases. Also the consult cases, because the slides go back after the reporting of these cases and we did not have blocks to use for staining. And we also excluded grade 3B follicular lymphoma, which were the presentation of the patient. So in the end, we had total 70 cases, 64 grade 1 and 2, and 6 cases of grade 3A. All cases were reviewed morphologically and underwent further medical record review. Ki67, PD-L1, and LAG3 immunohistochemical stains were performed on tissue blocks, and all cases were analyzed by 2 pathologists. Ki67, PD-L1, and LAG3 stains were scored in the area of maximum staining in each case. So now coming to the results. The median age at the time of initial diagnosis in our patient cohort was 59 years. Median follow-up time was 4 years. We had an equal male to female distribution and ratio 1:1. Grade 3A, as I previously said, were 6 in total. Grade 1 and 2, 64 cases. And the maximum patients, majority of them had stage 4 disease at the time of initial diagnosis, which account for 44% of our cases. It's taking a little time to transition to the next slide. All right, here we go. B symptoms and elevated LDH was present in 6 cases, and bone marrow involvement was identified in 39% of our cases. Follicular lymphoma transformation happened in 9 patients, and out of these 9, 6 patients developed transformation into diffuse large B-cell lymphoma, out of which 4 patients died. Total deaths were 14 in our cohort, and out of these 14 deaths, 7 deaths were because of the complications related to their follicular lymphoma. Flippy score was 0 in 9 cases, 15 cases showed score 1, 20 cases with score 2, 15 with score 3, and only 3 cases had score 4, and it was unknown in 8 cases. Sorry for the delay, it's taking time. So what was the first action after initial diagnosis in our cases? 24 patients had just initial upfront observation, and a total 46 cases undergo treatment. Out of 46 cases, 41 had treatment with various combinations, like only single agent rituximab or in combination with various chemotherapeutic agents, and some get even the maintenance therapy, and 5 patients had only radiation. Median progression-free survival was 1.6 months. Progression-free survival at 5 years was 25%, and overall survival at 5 years was 86%. And we defined progression-free survival as the time from initial diagnosis to the initiation of first treatment or death, whichever occurred first. Now coming to the results of the Ki-67 proliferative index. So this is the algorithm that we followed for Ki-67 evaluation. So we selected area of maximum staining, and in that area we had 10 consecutive follicular and interfollicular areas, and we counted number of positive Ki-67 on each of them and took an average of staining for separately for interfollicular areas and follicular areas. And then we did the analysis and their association with the overall survival and the progression-free survival from date of initial diagnosis using Cox regression. This is an example of one case from our group, low-grade follicular lymphoma, and you can see it's like diffusely positive for Ki-67 nuclear stain. These are vague nodular areas, so these is follicular areas, and the area in between is the interfollicular area. This is the high magnification of the same area, and you can see that both areas are showing high proliferative index. As comparison to the last case, this case shows high proliferative index only in the follicular areas with relatively lower proliferative index in the interfollicular area. And then this is also a case from our study which showed hardly any positive staining with Ki-67, both in the follicular as well as interfollicular areas. And that was the reason that we scored follicular and interfollicular areas separately, because it was showing a huge spectrum of staining pattern. This very nicely shows the comparison of the interfollicular and follicular area Ki-67 in our study. The range overall is pretty similar in both groups. However, you can see the median is 10.9 for interfollicular and 28.97 for the follicular, and the median is 7.1 in the interfollicular, and median for the follicular is 27.5. So there is difference. And this is list of all the grade 3A follicular lymphoma that we had in our group, showing equal gender distribution, and you can see the variation in the range in the staining of Ki67 in follicular versus staining Ki67 in interfollicular area. And this is similar to what we saw for the low grade, that is grade 1 and 2 follicular lymphomas also. So in univariate analysis, Ki67 follicular area was not associated with progression-free survival or overall survival. So this is in contrast to most of the studies that are published. However, we did find a significance of Ki67 score in interfollicular area that was highly associated with shorter progression-free survival with hazard ratio of 1.32 per 10 units of Ki67 and 95% confidence interval. Results were similar, adjusting for FLIPI score. This is a nice graphical representation of interfollicular Ki67, and here we found no association with the predicted overall survival. But in contrast to this, here you can see the progression-free survival decreases as we go from 0 proliferative index and increasing gradually to 30 or more. So this was a significant association. In contrast to interfollicular area, follicular area did not show any association with either overall survival or progression-free survival. Now coming to the results of the PD-L1 stain. So this is the algorithm we use for scoring PD-L1 stain slides. So in contrast to the follicular area, here we did not count in consecutive areas. We selected random, which were showing random follicular areas only, which were showing maximum staining. And then we did the counting under the oil immersion lens in 10 such fields and took the average. And then we scored them based on score 0, there is no staining at all. Score 1, rare positive cells. Score 2, occasional staining, we took as like 2 or 3 positive cells. And score 3, if 4 or more positive cells show any staining with PD-L1. And then the association of the PD-L1 was analyzed with overall survival and progression-free survival using the Cox regression. And we called it Mike scoring system, because Dr. Linden helped me with that. So this is the distribution of the PD-L1 cases, and you can see that 23 cases had score 0, so no staining, and 19 cases showed score 3, which is 4 or more positive cells. Unfortunately, we had 5 cases here where the tissue was insufficient and we could not analyze, so we were down to 65 cases for the analysis of the PD-L1 as well as LAG3. This is a nice case showing beautiful staining with PD-L1. And you can see here the staining is in the follicular areas. You can see some staining in the interfollicular areas also, but we counted only in follicular areas. And we did not find any association of PD-L1 with overall survival or progression-free survival. Now coming to LAG3 results. We used a kind of similar algorithm that we use for PD-L1. The overall score pattern was a kind of different. So here we had only score 1, 0, 1, and 2. 0, no staining, 1, rare positive cells, and score 2, 10 or more positive cells. It was a difficult antibody to validate. And then we counted the cells in the similar way to the PD-L1. We selected 10 follicular areas showing maximum staining, and we counted 10 areas under high power field oil lens and took an average of those. And this is the distribution of the LAG3 LAG3 score. As I mentioned that we were short of 5 cases here, so this is the analysis of 65 cases. Score 1 was noted in 49, which was rare positive cells, and score 2 in 16, which was 10 or more positive cells. We did not have any score 0, so we did not have any case with like no staining at all. These are the pictures from one of our cases showing LAG3 staining, low magnification and the high magnification. And we did not find any association of LAG3 with overall survival and progression-free survival. So in conclusion, our data suggest that intrafollicular area Ki67 score at the time of initial diagnosis is prognostic to predict progression-free survival in patients with follicular lymphoma. However, we did not find any impact of Ki67 score in follicular area on clinical outcome. The relationship of that significant finding of interfollicular area Ki67 appears to be linear and does not change when adjusting for FLIPI score. We propose that Ki67 proliferative index should be scored in the interfollicular areas to assess the prognosis in follicular lymphoma. PDL1 and LAG3 do not show association with overall survival or progression-free survival in our cohort of patients. And we even did the analysis comparing with each other, and we did not find any association of even PDL1, LAG3, or Ki67 with each other. We had certain limitations in our study. Of course, the first thing is the overall, we had limited number of cases. We ended up excluding a lot of cases. So starting from 137, in the end, we have only 70 for Ki67. And then further, we lost 5 more cases, and we had only 65 cases for LAG3 and PDL1. Another limitation is that we started study from 2003, so we had a mix of cases. Cases who underwent rituximab therapy and the patients who were diagnosed and treated before the initiation of the rituximab therapy. So we could not apply FLIPI2. And it is very challenging to analyze the Ki67 proliferative index in the interfollicular areas, because there are several other cells in the interfollicular areas which are dividing, like T cells, and they all pick up Ki67 stain. The future direction of our project. So currently, Hira is working on doing the digital analysis of whole scanned Ki67 slides. And main purpose is to do the standardization of scoring in the follicular and interfollicular areas in our cases. And we'll see what the results show. And also to compare that result with a pathologist review. Dr. Bakanova very kindly introduced us to Czech Republic Lymphoma Group, and they are interested in doing a collaborative study with us. It's very exciting, and we look forward to it. These are my references. And Ki67 part of this project was presented at American Society of Hematology annual meeting in December last year in Atlanta. And later, our abstract also won the 2018 Ernst Award that I received at the time of graduation in June. With this, I thank you all for your time, and I'll be happy to take any questions or any comments.
Congratulations.
Thank you.
This is a very good project. You may have mentioned this before, but I may have missed it. Did I understand that counting was done manually? It wasn't by image analysis?
No.
That's what you are trying to do.
Exactly. So the data that I presented at ASH, that had only the manual image counting that we did under microscope. And we want to standardize it. That is why now we are in the second phase, and Hira is doing the digital analysis of all Ki67 cases. Yes, Stephanie.
Aqsa, that was a very nice presentation. Thank you.
Thank you.
Does your data suggest that the clinician should not consider using immune checkpoint inhibitors, either anti-PD-L1 or anti-LAG3, in treating follicular lymphomas?
That's a very good question. Actually, PD-L1, if you see in general, PD-L1 has been used as immunotherapy with good results in several cases. But the data here is so conflicting, and that was our purpose of doing that. Probably we would find something, but unfortunately, we did not find any association. But as I mentioned, our cases are limited. We have only 65 cases. So if we can have a study which is larger, and we never know if we can get some results. But so far, yes, it's what we are getting here. Yes?
Any thoughts about prospective studies using flow cytometry to sort out the populations?
Yes, and the study that I mentioned in which they saw the expression of PD-1 and LAG3, they use flow cytometry. And that will be a very good idea, because then you can have, only prospective study will give you that type of material that you can use. And I think it's a good idea to do that, definitely.
Take a long time to accrue a number of cases.
That's true, yes. Because these are not very, commonly diagnosed, and mostly, many times consult cases was a large portion of our study. And it was very sad that we ended up excluding them, because it's very hard to get material for the consult cases because they are all from outside.
What is the localization of PD-L1 in the cells?
So in the cells, what we saw, so actually I have the dual staining, PD-L1 and CD20. So we did see, that it is in the B cell population, the neoplastic population, and we did the scoring only in the follicular areas. So there was, of course, staining in other, like macrophages or other cells. We did see some dendritic cell staining. So we kind of excluded those cells when we were putting together the scoring for PD-L1.
So what is the significance of Ki-67 or high proliferative index in the interfollicular area in terms of the disease progression for follicular lymphoma?
So we did find the significance of interfollicular Ki-67 with progression-free survival, but we did not find any significance with overall survival. And that was true for both follicular and interfollicular. However, in contrast to the previously, majority of the studies talk about having a significance of proliferative index in follicular area with progression-free survival. And we did not see that in our cohort.
Is there a mechanism which explains the...
That's actually, this is what we are also thinking, and we did some exploration. So we did dual staining, Ki-67 and CD20, to see what are the exact Ki-67 positive cells in the interfollicular areas, because we know there are like tons of other cells that can show Ki-67 staining. And so we used dual staining, that Ki-67 was brown stain and CD220 stain to highlight the neoplastic B cells. And it was very interesting to see we have mix of both types of cases. Like for example, in this case, Ki-67 is positive in B cells. So what we evaluated in terms of the scoring is accurate. But if you look at this case, you see plenty of brown staining and you don't see any red staining. So this means these are not CD20 cells. These might be CD3 cells. So this is a very complex area. That is why, this is one of our limitations, that we are not sure, but at the same time, we feel like we cannot entirely exclude this point, because we did see cases which do have CD20 positive cells in the interfollicular area with significant Ki-67. Yes?
Aqsa, of course, in an individual case, there's a lot of variation in Ki-67 intensity of stain. You can have very weakly staining cells and you can have very strongly. What was your cutoff? Did you count all cells regardless of the intensity of the staining, or only the strongest, or what did you have a cutoff? Because I think the difference in the studies in literature could have a lot to do with the eyeballs of the person
Exactly.
who's doing the assessment.
Yeah, we totally agree. This is a very good point, and that is the reason why we are doing the digital analysis, because we want to exclude that, element.
So what will the cutoff be in your digital analysis?
We haven't actually done all the cases, but we are actually curious to see what that would be.
Get the
And,
data, maybe
yeah.
run different variables.
No, it will be really helpful, and then of course we can address this point of seeing what is the variation in the staining, because eyeballing, it would be very difficult to do the intensity. Yes.
Very nice presentation and study. Did you do multivariate analysis for the Q67 with any of the outcome variables?
So we did that, but the number of events was less, as I discussed with Ryan, and actually our statistician, he's here. And but we ended up doing only the univariate because the total number of events was limited in our study. It was not a lot.
We did Flippy for PFS.
Hmm.
That's multivariable.
And your progression-free was to treatment? Is that was one of the?
So progression-free was either the first treatment or the death, whichever occurred first.